Well, folks, welcome to Chapter 26 of the Bouncebacks Critical Care Book Club. We started this in 2021, and it was hard to imagine that it was going to take this long to get through all these. You could have added it up, I guess, but with a few breaks for holidays and summer vacations, we are still at it. We're going to get through Chapter 28 and the end of this year, and then do the last two chapters in the fall. And I am really excited that we have a fantastic panel here, and I'm just going to introduce folks one by one. First is Jarmin Mikhail, and she is one of our residents in internal medicine at Adena Regional Medical Center. Mike Pallaci, a friend as well as a researcher, speaker, and faculty at SUMA in Akron, and Professor of Emergency Medicine, OU. So Mike, welcome. Joe Shiber, Professor of Emergency Medicine, Neurology and Surgery, and Director of ECMO. This is in Jacksonville, Florida. And then George Willis, who has been on the program before, and George is Associate Professor, Department of Emergency Medicine, University of Texas Health Center in San Antonio. And I am really excited because this case here, it's a tough one, and for this version of the Bouncebacks book, we have 4 of them, but for this version of critical care, we really focus on the return visit and the different steps where the patient, unfortunately, typically will decompensate. We go through different possible literature-based choices that we have, and we see then what the actual clinician did, we see what happened to the patient, and then we get to another decision point. This case here, we're going to concentrate, or at least I should say start just a little bit with the first visit, and the fact is that this patient actually came in, and it was not really very clear what was going on with this patient when the patient first came in. So let me bring up this PowerPoint here, and I just want to also make sure everyone is aware that there are no disclosures at all. Everyone will get 1 hour of Category 1 CME, and there'll be a QR code at the end that you can scan on to get your CME credit. This is our, like I said, 26th of these Bouncebacks Critical Cares, and all of them, except for the first one, can be seen at EM, like emergency medicine, so embouncebacks.com. So if you want to see any of the previous episodes, you can, with a lot of really fantastic speakers. And here is a little bit more of the specs from our panel from here tonight. So no one had anything to disclose. I want to just start talking about a 22-year-old woman who presented, and she told us in the emergency department, as many of our patients tell us, her own diagnosis. And we sort of make some jokes, Dr. Google, that sort of thing, WebMD. But in the end, sometimes it's hard to get away from that. And we have one case, the case of Jonathan Larson, who was the director of the musical Rent, and he actually went into the first ED before being misdiagnosed twice and then unfortunately dying of ruptured aortic dissection. George knows this case, as well, probably a lot of us do, but he told the first ED, he says, I ate a bad turkey sandwich, and that's exactly what they came up with, was food poisoning. So these sinus symptoms are pretty pervasive, and they can lead us astray, although it's a common thing that can happen. So we're going to start with the patient's first visit, and the visit here, I'm just going to put it up, and I just want to talk about just very briefly the initial presentation, and then we're going to go into some questions about this first visit and some things that we could have done maybe to make this patient safer, maybe to hopefully help with the diagnosis. So if you look right on the top here, I think it's going to jump out to everybody. She presented at 6:14 in the morning, so wherever the transition was, if it was at 7 a.m., well, you can imagine sinus symptoms are probably not going to be the highest priority after working the whole night shift, but she did have a pretty significantly elevated heart rate, 130. She told the nurse sinus congestion and pain for 3 days, and then told the physician maxillary and right frontal sinus pain for the past 3 days. Severely congested. She's a type 1 diabetic. She is tender with palpation of the right maxillary sinus, and she's diagnosed with maxillary sinusitis, and then it says acute for, whatever that's worth. And I wanted to just sort of start, Jarmin, with you, and just if you could, 60 seconds, maybe 90 seconds, it's tough when a patient comes in and they say, I have sinusitis, I want antibiotics, but there are specific diagnostic criteria to diagnose acute sinusitis or bacterial sinusitis.
Yeah, I mean, first of all, like clinically, they usually present with some symptoms like a purulent discharge. Now they would say probably nasal congestion or nasal like a blockage, stiffening, and also they would have a facial pain, fullness, or pressure, in addition to headaches. Some of them may also present with the fever, and usually the duration of the acute sinusitis should be like less than 3 weeks to say this is an acute sinusitis. Most of the cases will be caused like by viral, and the bacterial will be like less than 2%. If it's like a mucoid purulent with fever, and would expect like probably the bacterial one. So it's mostly like clinical diagnosis, in addition like to the physical exam with some tenderness over the like maxillary, frontal, sinus, and the facial tenderness in general.
Okay, so I'm guessing that folks that are watching are probably not thinking that this case is based on the fact that she inappropriately got antibiotics and developed C. diff and died, right? That is not what happened. But I want to get to a little bit of a subtlety because it does say she's a type 1 diabetic, obviously increasing our concern beyond a 22-year-old Olympian or an athlete or a person who doesn't have some other underlying condition, whether it's diabetes or something else. So George, here's the question to you. With a patient who has a history of type 1 diabetes, and I know that there's going to be some argument on different sides with this, but do you think that it's incumbent upon us to get additional information in the history? Is it incumbent upon us, for example, polyuria polydysphagia, that kind of thing? Is it incumbent upon us to check a blood sugar just because the patient says she is a type 1 diabetic?
So the difficulty with this, Mike, is that there's no standard for this. There's no literature that says that, or no guidelines that say we must check a finger stick on every single patient who comes into the emergency department with a history of diabetes. But certainly if there is some worrisome potential life-altering diagnoses, we certainly need to consider it, because as we know, hyperglycemic emergencies and crises most commonly present with life-threatening or life-altering diagnoses. Patients come in with myocardial infarctions and their blood sugars are elevated because of the stress that's associated, that could be either the inciting event that causes them to go in the hyperglycemic crisis or the other way around. As we know, there's lots of diabetic diagnoses where patients can have Fournier's gangrene or mucormycosis as a potential etiology or diagnosis that comes from poorly controlled diabetes. And I think kind of differentiating how controlled this patient's diabetes is vastly important, especially in the setting of this patient having abnormal vital signs. The thing that I find interesting here is that it's listed that she's a type 1 diabetic, and then 2 lines down it says that she takes diabetic pills, which there are no diabetic pills that treat type 1 diabetes. So it's a little worrisome when I see that she's either one or the other. But I
Right.
definitely think it's important to kind of get a sense of what this patient's control is, whether that be from asking her symptomology. I even go as far as asking patients what their fasting blood glucose is in the morning, especially when they're type 1 diabetic, to kind of see what their, or if they know their latest hemoglobin A1C, to kind of get a sense. And if they don't know, or if they're not checking their blood sugars, then certainly a very quick and easy test to do is this, what I call the 6th vital sign, which is to get a quick finger stick and see what that patient's blood sugar is at the time of their evaluation.
Well, here's you. I mean, you obviously, this is like your big area of interest and expertise. Of course, you're, I'm sure, asking those questions. Although there are a lot of patients with diabetes, type 1 and type 2, of course, that go into EDs all the time for totally unrelated complaints. I'd like to think in my own practice that I would key on it and think about what a blood sugar could be, or if the patient even has symptoms of that, as you're talking about. And we're going to ask Mike Pallaci in just half a second here if there is some sort of standard of care with that, and hard to say, definitively one way or the other. But before we get there, this was sort of curious to me in the chart. And I just sort of went to the next slide here and highlighted in red here. And Joe, the doctor obviously didn't bypass them that the patient had elevated pulse, and they did write an order to have the pulse checked, but it wasn't checked. So if you could speak to 2 things. One thing is something that I think we all, or experienced folks, know about as far as tachycardia being something that's concerning. But the second thing is, wow, the physician not only wanted it rechecked and ordered it for be rechecked, but it wasn't rechecked, and then the patient was discharged home.
Yeah, so the tachycardia, of course, is a glaring abnormality in the vital signs there. And it's, of course, it's non-specific because it doesn't necessarily tell you what the patient is sick with. The person could have just been in distress from their severe sinus pain, but you would expect for them to have addressed it and see if that heart rate would have gotten better. Up front, you would say, well, is 130, certainly not a dangerous heart rate in a 22-year-old, but it's no way that you could ever discount it as normal. So you would have expected to have had some evaluation or follow-up. Now, one thing I will mention is, the heart rate going together with the blood pressure particularly will give you a reasonable idea of if it's critical or not. The stroke, the so-called shock index, which is heart rate divided by systolic blood pressure, is very reasonable in this patient up front because your systolic blood pressure is normal. It's even mildly elevated, but that doesn't mean that there's no reason to worry about the heart rate. I absolutely would have followed up with it, and it does look like the physician meant to, and it just fell through the cracks. Because if it wasn't because the person was already so-called critically ill, if it was simply because of their pain, then you would have expected to have the physician address the pain using some nasal saline or decongestive or mild analgesic, something to have addressed it before you would have said, I'm repeating my vital signs and sending the person out. So I do think that was basically a mistake that just fell through the cracks. But the only time I think you can say, well, maybe I'm going to discount it. Well, again, say discount it, but would still let the person leave with it mildly elevated would be if it was something that you've proven isn't an issue. I think this is not the case here. The only other thing I also would mention is a heart rate that's non-variable, meaning if her heart rate was staying at 130 solid and not changing, that goes against sinus tachycardia. Even in sinus, you have variable heart rate. So I also would be concerned that maybe this was a tachydysrhythmia if someone had maintained the elevated heart rate at one consistent number. I don't think she was on a monitor, but if she was and it stayed at 130, I certainly would also have ordered an EKG to make sure that this wasn't some kind of a tachydysrhythmia.
So, clearly what you're saying is we get a repeat heart rate and it's 160. We're really concerned. It's back to, 85, and we're pretty reassured that it's normal, but it really would have been nice to have that. So I'm going to quote a study, then I'm going to ask Mike Pallaci a question. But before we do that, I want everyone to think about this. So we have, around 100 people on this call here, and I want us to think about this. Standard of care is really C- care. And I've talked many times about moving from standard of care to excellence in care. That's our goal. Obviously, that's what we expect of ourselves, right? So I just want to think about this. Was it a deviation of standard of care if there was a bad event? And we sort of know that was the case because this is a Bouncebacks case, of course, right? Was this a deviation of standard of care for this falling through the cracks, Joe, like you're saying? So before we get into that and ask Mike that question, I'll very quickly quote the Sklar study that I've quoted many times in the past, where they looked at almost 400,000 patients, University of New Mexico, and patients who died a potentially avoidable death within 7 days. And they found the biggest theme with those, that 71% of those had unexplained tachycardia. So certainly a potential marker for bad problems. I have a study group. Mike Pallaci is one of the participants, and actually David Sklar, who wrote that study from Annals, is one of the study investigators also, where we're looking at that right now. And we actually are at the point we've had RB approval, and we're waiting for the data to come back from the hospital. So we're going to get that thing written up, and super excited to find the results. We're looking not only at tachycardia, but also tachypnea, which obviously wasn't present in this case. So if folks have had a second to ponder that thought, was this a breach in the standard of care? You could say probably not, but it wasn't like the best care, right? Because something did fall through the cracks, as well as maybe a few other things that we could have done better. But Mike Pallaci, let me give that question to you, and I know there's not a definitive answer, but if there was an adverse outcome, how might this play out legally? And I wanted to ask you to talk specifically about the documentation. You're the chapter author for documentation and Corpendium, and your expertise with this, as well as years of experience, is something super valuable. So how would this play out documentation-wise, and what could have been done better?
Well, Mike, let's just say that if there is a bad outcome in this case, the doc is going to become very, very familiar with our co-investigator, Dr. Sklar. Because that paper that was written, I believe it was published back in 2007, has really become well known. The conclusions of it have become well known. It's worked its way into residency training curricula. It's worked its way into clinical policies and guidelines. Even with my group that I work with in Akron, we have a hard stop and a whole clinical management tool that gives us an algorithm if we're thinking about discharging a patient with tachycardia, what to do, because it has become common knowledge that this is something to watch out for, and it's a very risky thing medical legally, and a dangerous area for the patient. So the four things that Sklar found in that paper that were associated with patients who ended up dead within 7 days of an ED discharge were a decompensation of chronic disease, atypical presentations of common problems, someone who had a social or a mental health issue or substance abuse issue, something that would prevent them from coming back reliably, and then abnormal vital signs, of which tachycardia was the most common. So discharging a patient with tachycardia is not a violation of the standard of care. But going back to what you were talking about with the documentation, there's really little to no medical decision making listed here. And if we were okay with a heart rate of 130 because we were going to attribute it to something else, it's kind of hard to attribute a heart rate of 130 to pain. I mean, 100, 110 maybe, but 130 is pretty high for that. But whatever the thought process was that made him think it was okay to discharge them, it's not documented. So we just don't know what the thought process was. And the fact that they ordered a repeat pulse, as you and Joe both mentioned before, just kind of really digs the hole a little bit deeper, right? I mean, you wanted to recheck it. I tell my residents all the time, like, if you order a test and it's not back, it's never a good idea to just say, never mind. I didn't really need that after all. They can go home. It's kind of medically lazy, but it's also medical legally dangerous because you obviously thought you wanted that test, whatever it is, and then you let them go home before you got the results. So, those two things are definitely going to be major topics of conversation if there's a bad outcome here.
Yeah, and what we've talked about in the past, the chart needs to tell a story. It needs to be an argument for why what you did was reasonable and why what you didn't do didn't need to be done. So what happens is the patient is sent home. 2 days later, she's back, and I'm just going to briefly summarize the return visit here. History of diabetes. According to her mother, she's been anorexic, vomiting, not taking food and fluids for 4 days. Unable to provide any details of why she's here. And now, Joe, we talked about the heart rate earlier, and we don't know that it would have been this, 5 minutes later, but at least 2 days later, it is significantly elevated at 154 beats per minute. So, Joe, I'm going to just sort of start with you right here, and we could talk about the labs. Glucose 662, ABG 7.12, PCO2 is 15. So let me, and there's the true serum bicarb is 9. So I think the answer to this question is going to be pretty obvious, but just talk to us, though, briefly about DKA, HHS, and maybe some subtleties as far as how we're differentiating between those.
So the question of, is she in DK or HHS? The answer is yes, she's in both. She's crossed over. She very likely, again, if she was on an oral agent, she was a type 2 to begin with. Type 1 to type 2 is probably more of a historic, type 1 are people that actually have autoimmune islet cell destruction. It doesn't matter even the age necessarily, but typically a younger, and type 2 typically had been older, and that's more insulin resistant. But now we know that there's teenagers that actually become type 2 that just have resistance, metabolic syndrome, and so forth. But a type 2 can easily convert to a type 1 in terms of lacking insulin when they actually have pancreatic exhaustion. So their islet cells are pouring out insulin if they have more resistance. And so that's why the type 2s can become DKA prone. So she was very likely a hyperglycemic that was HHS, but at some point she's crossed into now in DKA. So the criteria for DKA she certainly meets, and that she has acidosis, her pH is 7.1. She has a serum bicarb that's 9 and has positive ketones, but with a glucose that's actually greater than 600 and with an abnormal mental status, she also has criteria for HHS. So I believe that it was very likely that she was HHS crossing into DKA. So I think that that's kind of where she stands. She does show that she has a reasonable amount of respiratory compensation with on her ABG. She has a PCO2 of 15. So fortunately, as a young person, she very likely is Kussmaul breathing and is helped by inducing a relatively profound respiratory alkalosis. That's the reason why her pH is still 7.1 and not necessarily in the 6s, because she's helping herself by that compensation, thankfully.
Right. All right. So George, let's move on to you here, and sort of 3 different thoughts. First, thoughts, and we sort of alluded to this right before the call started, so maybe we can get into that in a second here. But initial resuscitation steps before administering insulin, and then thinking about insulin, just giving it as a drip versus a bolus beforehand. And then we can just start with that, and then I want to get all of our thoughts on administration of bicarbonate.
Sure.
So I want you to start with how we're managing this patient here that we're seeing in front of us with a sugar 662 in these labs.
So the initial thing, obviously, is you're going to want to make the diagnosis. And in making that diagnosis, as Joe alluded to, you're going to look at the criteria. What is this patient's bicarbonate? What is their pH? What is their sugar? And then one of the important things that we have to consider is what is their potassium. Before we start the initiation of insulin, we have to know what their potassium is. There have been a handful of patients. There's not many. There are a handful of patients who will have hypokalemia on presentation with DKA. It's not common. As we know, most of these patients are volume down. As a result of them being volume down, they're going to have contraction of their volume. And as a result of that, they're going to be their concentration of potassium inside the blood volume is going to be higher. On top of that, they're going to have the acidosis presence, which is going to force potassium out of the cells and into the blood and into the serum. So they're going to have what I'm going to call a pseudo normokalemia or pseudo eukalemia as well, or a pseudo hyperkalemia that's present. In reality, these patients are going to be total body potassium down though. And so as a result of us giving them insulin, we could obviously push their potassium back into the cells. Obviously, we're going to give these patients fluids, which is going to decrease that contraction, and as a result is going to lower the potassium potentially to a critical level. Most of these patients will have osmotic diuresis, which is going to get rid of potassium in the urine, as well as potentially vomiting, which is also going to affect the potassium as well. And so these patients are going to need potassium supplementation if their potassium is lower than 3.5, which is what the guidelines say. So knowing that potassium is going to be important. The second thing we're going to need to do is fluids. These patients, regardless of if they are in HHS or in DKA, are volume down. The average for DKA is about 6 liters down. The average for HHS is anywhere between 9 and 20 liters down. So these patients are very, very volume down as a result, usually of that osmotic diuresis. The reason why IV fluids is important is we know that insulin is the mainstay of therapy, especially for diabetic ketoacidosis. And the problem is that if we know that and we just say, let's just give them insulin, what ends up happening is insulin pulls glucose out of the blood volume and into the cells. Well, glucose takes water with it wherever they go. They're best friends and they go everywhere together. So if they pull glucose into the cells, it's going to also pull water out of the blood volume and into the cells as well, which is going to further contract their volume and potentially put them at risk for circulatory collapse. So we want to hydrate these patients as much as possible before we initiate insulin therapy. So as I'm getting the labs back, I'm usually starting these patients with IV fluids. In adult patients, I'm usually, unless there's something that precludes me to that, being HFrEF or renal insufficiency to where these patients are on dialysis, I'm going to give them at least 2 liters of fluids.
That's what I was going to ask you. So that's like a pretty, and I think that's on our order sets too. It's like a 2 liter sort of bolus in there.
Yep.
So it's good, because let me ask you about as far as bolus versus drip insulin, because for some reason I think on our order set it still has a bolus that we all just have to manually go back in and uncheck.
So if you look at the guidelines from Katapji et al. In 2009, which is the standard of care up until August of 2024, when finally they have released a new set of guidelines. The old guidelines mandate, well, they put in their algorithm that the mainstay of therapy for insulin was to start them on an insulin bolus and an insulin infusion. And that bolus was 0.1 units per kilogram, and then the infusion was 0.1 units per kilogram per hour. The main reason why they did that was because they wanted to start the insulin into the system while the insulin drip was starting to drip. Remembering that an insulin drip takes time. You know, you're talking about potentially in a 70 kilogram person, 7 units over an hour, and that can take a long time to really get started. So that's what that bolus was for. However, when they went back and actually compared bolus plus infusion versus just starting the infusion, they actually found there really wasn't a lot of differences in terms of resolution of the DKA or resolution of the acidosis. So in the grand scheme of things, it doesn't really matter. And they actually found potentially harmful outcomes in the pediatric population. So in no circumstance do I think a bolus is necessary. A lot of times, again, start the patient on fluids and then just start the patient on the infusion, and that's usually plenty.
Okay, all right. So let me get to a question I wanted to ask everybody. George, I want to start with you. Is there a number lower than that number? In other words, pH of 7.0, 6.9, 6.8, because we have, I'm sure as all of us have seen historically low pHs, you know, and people sometimes amazingly who are talking to us, but is there a number below which that you're going to give IV bicarb? And I'll just ask that question to everybody. So just in the interest of time, just a pretty quick answer for everyone else. But George, if you want to spend just a tiny bit more time talking about this.
Okay, so my answer is there is no number. It is going to be completely dependent upon the patient. What does the patient have going on? Is the patient in cardiac arrest? Does the patient have profound hyperkalemia? Does the patient have circulatory collapse and shock because of their very low pH? But if they're staring at me, talking to me, hemodynamically stable with a normal or slightly elevated potassium, and their bicarb and their pH is 6.0, I might be like, oh my gosh, my anal sphincter is going to be this tight. But I'm not going to automatically just give some bicarb just based off of the number alone.
Okay, gotcha. Pallaci, give us like 20 or 30 seconds on that one, and then us, Jarmin, and then Joe.
I think my approach really mirrors George's. I mean, Tintinelli for the longest time said, I believe, 7.1. 2009 88 guidelines said 6.9. They got rid of the number and said you should consider it if it's less than 7.0 in the 2024 guidelines. But I do what George does. If I'm using, if they're hypotensive and have circulatory collapse and I'm going to be giving pressors, I'm not really convinced. You know, I don't really know how good the data is about the pressors not being effective in an acidic environment. But I think that's worth considering. But if they're in cardiac arrest or if I'm considering using pressure, that's where I'll consider. That being said, 25 years, I have not given bicarb for a DKA once.
Wow, that's good. That's impressive. I have to say that I am actually on that also. We haven't practiced this, so I don't know what Jarmin and Joe are going to say. So Jarmin, what are your thoughts? What are folks doing in the ICU? What have you done in your experience up on the floor?
Actually, I heard a couple things, like some people, they go by 6.9, some they go by less than 7, and some less than 7.1. But I agree, it's like depend on case by case. It's like it depends on the patient situation and other factors. Like usually it's not only the number that we go to, but definitely it has to be like low pH, definitely like less than 7.1 or something. But what specific number? I don't believe like they are usually like stick with the specific number for that.
Awesome. And Joe, what are your thoughts with obviously EM and critical care experience?
I'd be more likely to give the bolus of insulin than I would be bicarb. For the fact is that you're trying to shut off the production of the acid, which is still the ongoing ketosis and lipolysis. So the fluid starting for sure, because again, there's going to be some component of, as George said, of some dehydration causing the low blood pressure, but the majority of the cardiovascular collapse is due to the acidosis causing vasodilation and cardiac suppression. So starting the fluids and pushing the insulin. Again, I don't push insulin boluses on the majority of my patients, but again, if anyone here has ever had a diabetic arrest in front of them, that's the reason why they've arrested, from the acidosis. And so, like I said, you are trying to shut that off, the underlying process. You're not caring about the glucose, you're just trying to shut off the reason why they actually are breaking down fat and the lipolysis leading to ketone bodies. So that would be more likely. So no, I'm not very, very common at all. Very rarely would it be bicarb, and probably as agreeing with the other panelists, it would be when the person has hemodynamic compromise, almost in cardiac arrest, that I'd be thinking of it.
Wow, that's great. Everyone agrees. I sort of thought there would be someone that was an outlier on that one. So that is good to know. Now, Jarmin, you know, VBGs and ABGs, I think folks will know where I stand on this. I've said this many times in the past, but there was a study. There's been many, many studies on this, but one that I just asked you to take a peek at is where they used VBG combined with pulse ox compared to an ABG by Zesserson et al. Do you want to just give us a 45, 60-second summary of
Yeah.
that study and what they found and what the differences are between VBG and ABG?
Yeah, definitely. We always our thought is like, oh, ABG is like a gold standard to go to. But this was like an interesting study when they compared the ABG and VBG and critically ill patient in ED and ICU. And they found that the pH and the PCO2, the two things that we think is like they differ, like they are different in ABG than VBG. They found that they could in the VBG, the pH and PCO2 correlates well in the pH and PCO2 in the ABG. And also talking about the oxygenation, like getting the pulse ox by like checking the SpO2, the oxygen level was very close and correlates very well with the PO2 in the ABG. So by getting the VBG plus the SpO2, usually it was like correlating very well with oxygenation, acid base, and the bicarb level in the ABG. In addition to that, it's like the VBG is less painful, less invasive, and more safe with lower complication like puncturing the artery, damaging the nerve, and it's also easy to obtain while just like inserting the IV, peripheral IVs and getting those, getting the patient ready for the treatment. So it was interesting when they found that the VBG, by asking VBG or ABG, yes, VBG, it correlates very well if we're talking about pH and PCO2. Plus, they're checking the oxygenation by SpO2 and pulse ox.
All right. Well, Mike, I sort of like preempted not only this question for you, but the previous question. So I'm going to get your thoughts more in just a second as we go forward so we don't run out of time. But so what happened to the patient? And so we have three different decision points we'll talk about as far as when the patient returned. And so we talked about what we would do. So what did this actual provider do? So they gave the patient, and I'll just sort of come back here real briefly. The patient came in at 8:19 p.m. And this is sort of interesting, if I'm doing my math right here, 8:19 and 8:47. So it doesn't seem like they spent a whole lot of time waiting for the potassium to come back, but they gave the patient 8 units, or maybe that was just when they made their note. That's certainly a consideration too. I guess we could look at when the patient actually, in fact, I might have that here. Nope, I don't really have what the nursing time is. But anyway, at any rate, it sounds like they gave an insulin bolus. They started the patient on an insulin drip. They gave some IV potassium. Chest X-ray came back normal. EKG was normal sinus rhythm. So, Joe, this was actually a sinus rhythm, wasn't some other type of arrhythmia. But look at this. They rechecked the vital signs. Initially 154 heart rate. Now it's gone up to 166, and the blood pressure has gone from 158 systolic anyway, down to 106 systolic, and their consciousness is altered. So let's do this. Jarmin, why don't we go through some different items on a differential for altered mental status, and then we can talk about specifically at the bedside with these expert whisperers that we have on the panel here, what folks would actually do with the patient who, despite us doing what we know how to do best and what we've all talked about, is still getting worse. So, Jarmin, tell us what other things are on the differential for altered level of consciousness in a diabetic patient?
Yeah, we do have a couple differential diagnoses, actually multiple differential diagnoses for altered mental status, just like I would say probably in general people as well. So first of all, if we think about like systematic, like starting by the CNS, we would think about like seizure, stroke. We would think about like maybe space occupying lesion, brain mass, traumatic brain injury that could also present altered mental status. Alcohol by itself, especially with a thiamine deficiency, drug overdose can cause it. Infection, sometimes, especially in the old population, can cause altered mental status. And encephalopathy, if we're thinking about liver, like hepatic encephalopathy, uremia can cause like uremic encephalopathy. And if we're thinking about like endocrine, sometimes endocrine causes like hypothyroidism or even any hypoglycemia or hyperglycemia can both cause this. In addition to the electrolyte disturbance, we need also to keep in mind like hyponatremia can cause it, hypercalcemia. Many like we have to broaden like our differential diagnosis actually if we're thinking about people with altered mental status in general and also in a diabetic patient.
So it's sort of nice as we look through this list, most of these things are going to be picked up either with our labs or, I mean, psychiatric is not an emergent diagnosis to make, but just a few things that you mentioned, things like some sort of toxicologic type of problem or, substances, obviously, that's something we want to think about because those do happen in diabetic patients. And we have patients that come in DKI all the time. And one of those reasons is probably because of, poor compliance because of the substances they're using, as well as, their temperature and different things that you talked about. So Mike, I like asking you questions where there's not always a right or wrong answer. This patient is altered, but we don't at least have any history of head trauma. She comes in with her mother, right? We already talked about that. And there's no signs, let's just sort of say, of any head injury. And let's even say we're so good that we've looked in the ears, there's no hemotympanum, battle sign, raccoon eyes, all this stuff, right? Do you get a head CT in this patient, realizing the risk would be taking the patient from the critical care area, but CTs are pretty quick, or are you pretty confident and comfortable with the fact that her altered consciousness is because of this pretty significant DKA?
You ready for the radiology answer, right? The waffler answer, the sitting on heads. It depends, and that's because it really does depend, right? So, I mean, on one hand, you're right. You're hesitant to take them out of the critical care area, but even that depends on where you are, right? I work at one facility where the CT scanner is literally right around the corner from where their bed is, and we've got nurses everywhere. We can, it's 15 yards. I mean, it's literally right there. I'm a little less hesitant to send that patient to CT scan than I am, for instance, in a freestanding ER where I also work, where it is down the elevator, down a long hallway in a different building. The threshold to go to CT is a lot higher there than it is in the trauma center, where it's literally right around the corner from the resus bay. So I do think you have to have a low threshold, but you also have to have a reason, right? I mean, HHS, we know that it's part of the definition. It causes altered mental status, but you don't want to put all your eggs in that basket. So is there something else that's raising a red flag? Signs of trauma? Well, we don't have that here. Is there unilateral weakness? Is there, are they not improving as we resuscitate them? You'd expect it if it's HHS, as we start to resuscitate them, they get a couple liters of fluid, their vital signs starts to improve. You'd expect their mental status to improve. If that's not happening, then maybe we got to look for another cause of their mental status. Are they on an anticoagulant? That might drop your threshold even further. If you're worried about a head bleed. How severe are the mental status changes? Are they completely obtunded, or are they just a little sleepy and maybe takes a little more energy than you'd like to arouse them? So yeah, I'm gonna go ahead and I'm gonna waffle, and I'm gonna say it depends on
All right, Mike,
all those
I tell you
factors and
what,
probably a
buddy,
few more.
we'll put all of us in the footsteps here just for a quick yes or no answer. Mike, you're seeing this patient, this is what you've done. Let's say it's a couple hours later, or an hour, 12, 11 minutes later, whatever. Are you getting a head CT on this patient? Let's say if it is readily available, not down an elevator, down a hallway. Yes, no.
Has she gotten better? Has her
At
mental status
this
improved at
point,
all? It sounds like she's worsened.
right, she came in just after 8, and here it is almost at 10 o'clock, responding to painful stimuli only.
If it's readily available and she's not in shock with these vital signs I see right here,
Mm-hmm.
I would probably take her, but I would go with her.
Okay, all right, sounds good. Joe, what do you think? Yes, no for the head CT?
No, I don't think I would do a head CT immediately. I think there's reasons why. I believe she decompensated, very likely because her shock state worsened. Again, her blood pressure is lower. Even though she got 2 liters up front, not nearly enough volume. As George mentioned, this person was probably 9, 10, 12 liters down. So now she has a shock index that's kind of 1.5, 1.6, so severely high. She has not only a lower systolic pressure, but a very narrow pulse pressure that probably goes along with severe hypovolemia. The only other reason why you have a low pulse pressure like that, again, her pulse pressure was almost 70 and now it's less than 30. So hypovolemic shock, cardiogenic shock. So for her, probably not cardiogenic, probably hypovolemic. So, her pH is probably tanked now because she has a lactic acidosis, very likely on top of her diabetic ketoacidosis. And so I think that's probably the cause. And as Mike said, HHS certainly has abnormal mental status. Seizures can also be very common with the metabolic disorders with HHS, not just generalized, but even complex partial. So I think the fact that she's seizing is, again, not good, but at least it's an explanation for very likely that that was their the decompensated mental status. So I think I would hold off on the CT up front until I had a little bit more control of the situation.
Okay, gotcha. And sort of, fortunately, you also answered the question I was going to just ask, why is the patient getting worse? Before we get to George bringing this all together for step 2, then we'll go on to decision point C, step 3. So, Jarmin, yes or no? You're in the footsteps, you're in the ED, you're seeing this patient. Yes or no on the head CT for you at this point?
Probably I will wait.
You'll wait. Okay. And then George, do you mind just a quick yes or no in the interest of time?
Yeah, I'm not sending her to CT right now.
Okay. All right, good. So George, now to you, can you bring this all together for us, where we're at here? This patient is getting worse. We've done sort of all the stuff we know how to do. She responded to painful stimuli only, but then we'll see what happens next. But at this point, just give us a maybe 60, 90 second sort of overview where we're at and what other things that sort of pro tips we could consider.
Sure. So you got this patient who came in who's in probably, like as Joe described, probably in DKA and HHS. One of the things that we have not really discussed, which I think is very important here, is the patient's sodium. The sodium is extremely important in HHS. If you look at the equation for osmolarity, sodium is the primary driving force, and it is the primary driving force with HHS. These patients are oftentimes, as I said before, very volume down. And so that volume being re-established is super important, and monitoring their sodium is exceptionally important in this circumstance as well, especially if HHS is there. So you have this patient with HHS and DKA. We don't have a really good potential inciting diagnosis. Could have been this sinusitis. I'm actually wondering if she may have had an element of mucormycosis. It's possible. It's something that we don't actually know the answer to. But now we've done the things that we know how to do from a DKA perspective. We started this patient on fluids. We know what their potassium was, which we got the labs back, although they gave them some potassium and they started the insulin before they knew what the potassium was. The potassium ended up being 4.6, which is fine. So at that point in time, they gave the patient some potassium. They gave the patient continued IV fluids. I'm assuming, I'm making that assumption based off of what I'm seeing. And then they started the patient on a bolus dose of insulin and an insulin drip. But for some reason, she's still very ill. Her pulse got higher, her blood pressure got lower, and her mental status has changed. She came in, she was trying to follow commands. Now she's only responding to painful stimuli. So in this scenario, now I'm actually worried. I'm actually a little bit more concerned. Is my therapy not maximized? Have I done everything that I've needed to do? Or is there some potential thing, as Dr. Shiber alluded to, is there a potential sepsis that I'm missing? Should I be starting this patient on IV antibiotics? I think that this is an indication where maybe IV antibiotics may be indicated. As we know, starting patients who are septic need to be started on IV antibiotics very, very early. Should be started within the first hour. We're now a little bit after that threshold. So I need to start thinking outside the box. Is there something else that I'm missing? Do I need to take an ultrasound and look at their heart, see if there's any other potential things that are going in the lungs? I'm hoping that I would have had a chest x-ray back by now. I'm sorry, there's chest x-ray is back and it's within normal limits, but is there something else that I'm missing? As we know, chest x-rays sometimes miss pneumonias. So are there some other things that I'm potentially missing to explain why this patient, who I think that I am treating well, could potentially be getting worse?
Okay, so here is the outcome as far as what happens next, and we saw what has been happening and what we've done so far. So while arranging to go to the ICU, the patient begins to seize. Physician says, I gave Ativan 2 milligrams with a rapid resolution of the seizure. She remains altered, responding to painful stimuli only. It's diagnosed with DKA seizures, persistent vomiting, and dehydration. So let's now move to our decision point C, and I just want to let folks know we have folks from over 10 different countries all around the world, from most of the states in the United States. Folks, a lot of experience on this call. If people want to put stuff in the chat, ask any questions, the panelists were happy to have it, and I'm sort of monitoring the chat right now as we speak here. So, George, getting to you first, how should seizures in diabetics be managed?
So any patient with a seizure needs to have that seizure aborted as quickly as possible. As we know, the longer a patient seizes, the more likely that they're going to have possible persistent and permanent brain damage from that seizure. So we want to abort the seizure as quickly as possible. Most seizures last about a minute or two. So the old adage, all seizing stops eventually, is certainly at play. Most of the time they will stop on their own. However, we want to stop it as quickly as possible. So I still say, regardless of what their etiology is, I'm starting with a benzodiazepine, and I'm starting with an appropriate dose of a benzodiazepine. 1 milligram of Ativan is not enough. I'm trying to stick to as close to that, at least 0.05 to 0.1 milligrams per kilogram of Ativan IV, if available. If that's not available, then I will use lorazepam and midazolam. And those are my usual go-tos. If I've given that patient an adequate dose of a benzodiazepine and it hasn't worked, then I repeat that dose to see if it works again. If it doesn't work then I'm doing two things. One, I am going ahead and loading my anti-epileptic. And then second, I am thinking outside the box. Is there something else going on? Did this patient who received a bolus dose of insulin and then a subsequent insulin drip, did they all of a sudden plummet their glucose down? It shouldn't have happened, but did all of a sudden her glucose, is it now 25? Does this patient, is this patient an immigrant or come from a homeless shelter who may have been treated for tuberculosis and may have isoniazid on board and have to think about isoniazid toxicity? So is there something else that could be going on that has made this patient who should be responding to my therapy not responding to my therapy? So I have to think outside the box. So I'm usually doing those two things. My go-to loading anti-epileptic is usually going to be levetiracetam or fosphenytoin, because I can give those patients that bolus very quick and I don't have to wait for anything to come back or wait for a pump to come on if I have to load phenytoin or valproic acid. So I'm usually loading with levetiracetam or with fosphenytoin.
Yeah, and really what you're saying here is, look, this patient has the diagnosis, right? And we'll get rid of the medicine, right, everything correct, but our job is not done, right? Yeah. And, especially if she worsens, it's time to go back and maybe get additional history from the mother, maybe do some other part of an exam if you thought there could have been some trauma, et cetera, or, look in her nose or back of her mouth for that mucormycosis, yep, which, I've seen in the past. And sometimes it's as easy as just looking, right? Yep. Which I'm guessing probably most people aren't doing a really detailed nasal exam on their DKA patients, right?
Absolutely.
Okay, so Mike, next question for you here. She's getting worse. She's only responsible for painful stimuli. She's seizing. Should we intubate this patient? And then we'll ask Joe if we do decide to intubate. And Joe, before the program you were even talking about, or maybe at the beginning of it, about diabetic patients who have died, right? This is a 22-year-old woman, so that would be obviously unbelievably tragic, of course, right? So, how we would do that. So Mike, the first question for you is, and maybe just like 60 seconds, so we do have some time for a little bit further discussion towards the very end here, because we're at 10 till. Should you intubate the patient at this time?
Well, the decision to intubate is critical in this particular situation because of the stakes, right? I mean, if she's not protecting her, she requires intubation, but you really, this is the most dangerous patient possibly in medicine to intubate for a lot of reasons. So some key points when intubating somebody, when considering intubation in someone in DKA, not just this particular patient, the classic beginner's mistake is to mistake tachypnea for respiratory distress, right? And to forget that they're breathing hard and breathing fast because they're trying to compensate for the metabolic acidosis. I've actually had to physically, well, not physically, but go and stand in between a medicine resident at the bedside who was about to intubate a DKA patient to stop them for this exact reason. So you can't do that. You can't mistake tachypnea for respiratory distress. On the other hand, you also don't want to mistake a patient who is tiring out, his respiratory rate is coming down because they're tiring out, for someone whose respiratory rate is decreasing because they're clinically improving, and then let them basically crash on you. So, that's an assessment that you really have to make at the bedside. In this situation, the seizure complicates things. The altered mental status complicates things. But you have to remember that it's not just their metabolic or their respiratory compensation that you don't want to take away from them. The act of intubating them can kill them, increasing CO2 during the intubation attempt while they're apneic. The acidosis that results from that can lead to hyperkalemia, that can lead to cardiac arrest. circulatory collapse. This is the classic C before A scenario where you have to optimize their circulation. You have to optimize the situation in general before you go ahead to intubation. I know Joe's going to talk about that a little bit as well, but it's not a decision to take lightly. And if you're going to if you're going to make that decision and pull the trigger, you have to make sure that these things are optimized first, and it's the right decision.
All right, so Joe, why don't you speak to that? Because this is a tough decision, and that's why this is such an interesting case to talk about.
Sure. So a lot of times I put these patients on high flow, not because of the oxygenation, but because of the CO2 clearance. You get about 25% of your minute ventilation cleared with high flow. So I know sometimes respiratory asks me, oh, high flow, their saturations. Yeah, I don't care about the saturations. I put them on 50 to 60 liters, sometimes on room air, because when they have Kussmaul breathing, and if you actually ever measure it, they're breathing 1.5, 2 liters per breath, sometimes 20 breaths. So it's not that they're tachypnic, but they're doing tremendous minute ventilation. So putting them on high flow will help clear their CO2 so that they don't tire out, as Mike said, because if they tire out and the CO2 goes from 15 even back to normal at 40, their pH is so low that they will arrest. So that can be an adjunct while you're waiting for their acidosis to improve with your IV fluids and your insulin. If I did have to intubate them because their seizure was so profound that I worried they weren't protecting their airway, I would minimize, just as Mike said, my apnea time. I would probably make sure that it was the most experienced provider and that we bagged leading up, pre-oxygenation with bagging and then paralytics and intubation immediately with no chance for the CO2 to rise. And then once they were on mechanical ventilation, you have to match the same minute ventilation of the ventilator as what the patient's minute ventilation was before. Because if not, their CO2 will rise, even if it doesn't rise above 40. But again, this patient had a PCO2 of 15. So even if it goes to 35, goes up by 20 points, yeah, pH drops acutely about 0.08 for every 10 rise. The PCO2, that would be dropping by 0.16. That would take her down again into the sixes. So you have to be generous with your tidal volume. This is not ARDS. This is not the time for instituting a low tidal volume. This would be someone that would be 8 to 10 cc's per kilo with a reasonable respiratory rate and ensuring a good minute ventilation ongoing.
Okay, so Jarmin, just a real quick question, then we're going to sort of get everyone to summarize their main thoughts here. As far as say the patient does get better and she goes to the floor just in the 20 seconds, 30 seconds, as far as when does the floor stop that insulin drip that the patient is on?
Yeah, let's say this patient is on the floor and started improving. We have to look for certain things before deciding to discontinue the insulin drip. One of them, we'll say glucose that's below 200 milligram per deciliter, and the other stuff we have to look at, it's the beta hydroxybutyrate. If it's less than some places they said less than 0.6 and some they said less than 0.1, or looking at the gap itself, we said the gap is close or the anion gap is less than 12. So either resolution of that gap or we have beta hydroxybutyrate that's less than 1 at least. And the other things that we need to look at is the pH, if it's above 7.3 or the bicarb level above 18. And the most important thing that sometimes we used to forget, it's asking the patient or checking on the patient to see if the patient is able to eat. That's the most important thing. Sometimes we met all the other criteria. The glucose is less than 200, the gap is closed, and the pH is above 7.3 and the bicarb above 18, but the patient cannot eat. And once we stop that drip and they start eating, they will start vomiting again, and they will get back to DKA. So this is the thing sometimes we miss, but this is really important too. So I will add to those criteria, if the patient is able or tolerating the oral feeding.
Nice. Okay, so we are at the end here. What happened to our patient? Her encephalopathy worsens, has a normal brain MRI, and then improves. She's discharged after 4 days with a diagnosis of DKA, altered consciousness, and most importantly, acute sinusitis. But George, we do not know whether it's mucormycosis, acute sinusitis. So for folks who have waited so patiently, thank you so much. We are really appreciative of everyone who has given us an hour of their time. We hope we've been true to that. If you scan the code here, you can get the CME credit. And while we're doing that, I'm going to put this back on in just 2 seconds here if you didn't pull out your phone fast enough. Jarmin, if you could give us a 30-second closing thoughts as far as the main thing you want folks to take away from our discussion here, then we'll go to Pallaci, Shiber, and Willis, 30 seconds each. I'll put that QR code back on. Jarmin, I think there we go. Unmute. We almost made it through the whole program without trying to
Can you hear me now? Sorry.
Yes, perfect. Start that one over again.
Yeah, so I think you were talking about specifically our case that we discussed today, right? Or tonight. Yeah, so first of all, probably I would check the glucose, diabetic patient. I know we don't have to do that all the time, but especially if the patient is showing some signs of infection, I would go ahead and check the glucose just to make sure they are not, because one of the precipitate factor for DKA, it's infection or even HHS thing. The second thing, we have to broaden our differential all the time. If we have patient, even sometimes we have oh, this is a DKA and this is whatever it is, but we have to broaden our differential, especially with altered mental status. And the third thing, as we mentioned, bicarb, for me, it's not the big deal to use. And the most important thing is resuscitation and insulin, and frequently checking their electrolytes and making sure their circulatory status is improving.
Okay.
Yeah. I think that's what I got from the case in general. But there's something that I'm just wondering if they check it during this ED visit was the lactate level. I was just waiting for it to see how much was the lactate. I'm not sure if I missed that in the slides or not, but probably I would, if I'm thinking this could be a septic shock, probably I'll check the lactate too to see how much is it, and for the perfusion too. Yeah.
Okay, awesome. All right, Pallaci, 30 seconds. The main thing you want folks to take away from the discussion today.
I'll make it even shorter than that in the interest of time. In the old saying, if the laryngoscope is a murder weapon, many of its victims are in DKA. So be super cautious with that laryngoscope, and if you have to do it, optimize conditions first.
I have done this job for so many decades and I've never heard that expression. I love it. I'm going to quote you on that. Joe, 30-second take-home points.
Definitely look at your vital signs, look at your heart rate, look at your pulse pressure. So not just your systolic, but your systolic minus diastolic. That gives you a tremendous amount of information on their cardiac function. VBG and ABG, remember, the sicker the person is with cardiovascular system, the more disparate they are. So the classic example of that in cardiac arrest, your VBG and ABG are completely meaningless. So if you're going to do a VBG, I think it's reasonable to check an ABG at the same time, so then you can see how well it correlates, and then you can follow the VBG. But I think in absence of knowing how well the person's cardiovascular system is, then I don't know if I would trust the VBG entirely, although it's quite useful. And I agree with everyone else in the panel, particularly Mike. Get your patient optimized for your intubation, minimize apnea time, because it's not a success to get the tube in place and then have the patient arresting on you.
George, fantastic, Joe. Good. George, give us the last word.
All right. Most important thing I think is super important. Don't forget that DKA and HHS are not always just due to non-compliance. There's so many times where patients will have overwhelming Fournier's gangrene, mucormycosis, a myocardial infarction, and we'll get these labs back and we'll say, oh, this patient's in DKA, let's just give him some fluids, we'll give him some insulin, let's check the potassium, and then we'll admit him to the ICU. And then the patient has had some overwhelmingly bad outcome as a result of missing something else. I like to call it the 4 I's: infection, ischemia or infarction, infancy, so pregnant patients can come in hyperglycemic crises, and then and only then do you think about insulin noncompliance. So think about those 4 I's as a potential inciting cause of why the patient is hyperglycemic.
Well, thank you, everyone who has joined. We really appreciate the confidence that you have. This has been an absolutely amazing panel. I mean, I could have actually, in fact, if you guys aren't doing anything until like midnight, I'm happy to stick around and suck that information out of your brains. But it's been really, really insightful. So thank you so much to the panelists. Thanks to all the participants who have been here. This is our next Bounceback Book Club on May 5th. We'll have one in June. Those are chapters 27 and 28. And then we'll start back up again in October. So thank you all so much who have joined, and we'll look forward to seeing you next time. Thanks again.
Thanks for inviting us, Mike. Appreciate it.
Thank you so much.
All right, bye, everybody.
All right, take care. Thanks again, Frank.